So good afternoon, everyone, and thank you for joining us for the Overdose Prevention Engagement Network webinar. Welcome to today's session, exploring the link between trauma exposure and substance use disorder. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenters. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions at the end of the session as time permits. We are offering CME, Social Work CE, and MCBAP credit for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email continuing education credit information after the webinar today. My name is Katrina Hernandez. I'm an engagement specialist with OPEN, the Overdose Prevention Engagement Network, and I'll be moderating the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and MCBAP credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication and storage disposal options. We assist groups all across the state in hosting medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock boxes for community and healthcare distribution. For overdose rescue support, we fund implementation of naloxone vending machine and distribution boxes, and we offer naloxone administration trainings. These trainings are offered as live, virtual, free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. For our presenters today, Shiva Sethi is board certified in internal medicine and addiction medicine. She has worked with Michigan Opioid Collaborative /OPEN since 2017. She also currently works as a medical director for several jails in Massachusetts and Maine, and she lives in Boston, Mass. Melissa is a licensed professional counselor with an advanced alcohol and drug certification, currently serving as a behavioral health specialist with OPEN. She brings extensive experience in mental health and substance use disorder treatment, harm reduction, and patient-centered care. Melissa has led stigma education initiatives, contributed to the development of implementation toolkits for office-based addiction treatment, and delivered trainings on addiction neurobiology, trauma, and medications for addiction treatment. Through her role at Open, she fosters community engagement with educational resources and programs, supports clients' access to SUD treatment, and works to expand education for partners, patients, and communities. So thank you both for presenting today.
Hello, everyone. As Katrina mentioned, my name is Melissa DeMars. I'm a behavioral health specialist for Open. Dr. Sheba Sethi and I will be presenting today on exploring the link between trauma exposure and substance use disorders. So we're going to begin with defining different types of trauma and how they show up in people's lives. Next, we'll look at what's happening in the brain and body when someone experiences trauma and why that matters for addiction. We'll also connect trauma and ACEs to long-term health and relationships, and we'll discuss practical ways to apply trauma-informed care for individuals affected by both trauma and substance use. Our goal in this presentation is to really move beyond the abstract ideas of trauma and make it tangible, helping you understand in real terms what living with trauma can feel like for a person. So trauma has a broad definition because it isn't just about the event itself. It is about how a person experiences and interprets the traumatizing event, making trauma deeply personal and individualized. SAMHSA defines trauma as something that can be directly experienced, witnessing in person an event that happening to somebody else, learning of it happening to someone close to you, or even through repeated exposure to distressing details. What matters most is the individual's internal response, how they make sense of it, how they label and assign meaning to it, and how it affects them physically and psychologically. So you could have two different people in the same car accident. The car's totaled, it was a serious accident. The person comes away pretty much unscathed physically, and their narrative could go, oh my gosh, that was terrifying. I could have died. I'm never getting into a car again. Their thoughts may spiral into fear and negative thinking. They may avoid driving or riding in cars, become more isolated, experience heightened anxiety and depression, and just have trouble taking care of their basic needs. Person B could come away with a narrative as, oh my gosh, I could have died. Thank God everyone is okay. They may feel shaken and nervous getting back into a car, but are generally able to carry on without significant distress or impairment. So both experience the same event, but their responses are very different. Trauma occurs when someone perceives their life, safety, or sense of control as threatened and becomes emotionally, physically, or psychologically overwhelmed. Responses are shaped by individual, social, and cultural factors, and trauma can affect anyone at any point in life. So here are the different types of trauma. Acute trauma is often a single event, very unexpected, shocking, produces feelings of horror and helplessness, very intense fear. We often associate these events with post-traumatic stress disorder, PTSD. You can see the examples of these events on the screen. Chronic trauma is exposure to repeated or prolonged traumatic events over an extended period of time. The body's stress response stays activated, which can lead to vulnerability to physical and mental illness and substance use disorder. Unlike acute trauma, which stems from a single event, chronic trauma has a cumulative impact that often leads to more complex and long-lasting effects. Historical, collective, and intergenerational trauma is physical, psychological, or emotional trauma that can affect different communities, cultural groups, and generations. Examples of historical trauma are slavery, genocide of Native Americans, colonization of indigenous peoples globally, collective trauma, 9/11 terrorist attacks in the US, school shootings, mass displacement of a community or people due to war or natural disasters. And intergenerational trauma is trauma passed down from one generation to the next. This could be children of Holocaust survivors, children of parents with PTSD, any family with relational issues or trauma. Complex trauma involves repeated, prolonged experiences of harm, often starting in childhood and within relationships where safety and care should exist. It's often referred to as developmental trauma as it disrupts brain development, attachment, and a child's sense of safety. It occurs commonly in the family context. Examples are abuse, neglect, parental substance use or mental illness, exposure to domestic violence. It can also be relational patterns, so caregivers who are physically present, but consistently dismissive or withdrawn, unable to attune to a child's feelings. Caregivers who alternate between nurture and rejection, leaving a child unsure of what to expect. Invalidating or minimizing emotions, teaching a child not to trust their emotions. Over time, complex trauma impacts identity, relationships, coping, and mental health. And many individuals with substance use disorders or serious mental illness report these early experiences, showing how deeply complex trauma shapes lifelong well-being. So this is the criteria for post-traumatic stress disorder according to the Diagnostic and Statistical Manual, which is the primary diagnostic tool used by mental health professionals. And I just want to pause here because this can get a little confusing. Trauma refers to the event and the person's experience, so the wound, the psychological, emotional, or physical impact of the experience. Post-traumatic stress disorder, PTSD, is when the wound doesn't heal and develops into a chronic diagnosable psychiatric condition. So this is the criteria one has to meet to be diagnosed with PTSD. So exposure to a traumatic event, such as the car accident we mentioned, re-experiencing of symptoms, so intrusive memories of the accident, hearing noises associated with the crash or nightmares, avoidance behaviors, won't ride in a car, cognitive distortions, believe it will happen again, riding in cars are not safe, may turn into fear of not being in control of other aspects of their life, increased arousal, so hypervigilance, easily startled, irritable, overwhelming sense of dread when attempting to ride in a car. It can also look as like dissociation, so that means feeling disconnected from oneself or immediate surroundings, may have a flat affect, feel a bit slowed. This is the diagnostic criteria. Thank you. Symptoms have to be present for more than 1 month and cause impairment in social and/or occupational functioning. Okay, so these are just some examples of traumatic events or circumstances. Most of these on the top, or all of these, are big T's or big traumas. So again, they're the unexpected, life-threatening, catastrophic events. These events would horrify any of us. So it's easy to understand how they might lead to long-term effects. It's easy to validate. And while these events are certainly traumatic, it's important to remember that trauma can also develop from other kinds of experiences. So if you look at the second row, these are called little T's or traumas, which isn't aptly named because they're not really little, but they don't always create a dramatic image for us, like a natural disaster or assault, but they are deeply personal and they have long-term ramifications. For example, if someone says, "I was neglected," that may not feel very impactful, but the impact becomes clear when you hear the person's story. And what matters, again, is the individual's internal response. So how they made sense of the experience, how they kind of explain how they've adapted through life, gives you more of a picture. And that isn't something people walk around and tell people unless you're a behavioral health clinician and, then you get a full history or you assess for trauma. The impact that trauma has of not developing a sense of self or feeling safe in relationships has a very serious impact on all domains of a person's life. So this is complex PTSD. And again, this is when the wound is repeated and prolonged, reshaping not just fear responses, but a person's entire sense of self, emotions, and relationships. So PTSD and complex PTSD have core symptoms of re-experiencing the trauma, avoidance, hyperarousal. The time, duration, and developmental years differentiates the two. The DSM does not recognize CPTSD. A lot of that is concern of symptom overlap with PTSD and other disorders and ongoing research on complex trauma. It is recognized by the Internal Classification of Diseases, the ICD-11, which is a diagnostic tool developed by the World Health Organization. So what I really want you to take away from this slide in complex PTSD is it's not just symptoms. It profoundly affects a person's sense of self, relationships, and ability to feel safe. Individuals may struggle with a deep sense of shame, struggle with a sense of identity, trust, is an issue. Intimacy is difficult. Emotion regulation, follow through on tasks. It really reflects how deeply this kind of trauma can disrupt core aspects of all domains of a person's life. And we do have a case study that hopefully helps put this into a clear picture. Trauma is common. 70 to 90% of people in the US
Next slide.
have a lifetime history of exposure to at least one traumatizing event. About 6% of people live with PTSD. And among people with substance use disorders, lifetime prevalence of PTSD is thought to range between 26 and 52%. And I'll hand it over to you, Sheba, to discuss neurobiology.
Thank you. Okay, so now we're going to shift and talk about neurobiology. So your central nervous system, which is CNS, it's abbreviated CNS on this slide, is made up of your brain and spinal cord. It's like your body's control center, managing everything from your thoughts and emotions to your movements. When someone experiences stress early in life or lives with ongoing stress, it can change how the brain develops. And these changes can include areas such as memory and emotions, fear, thinking, the way you think, and a stress response. And you'll see this circle in the slide, and there's a gray word, epigenetics. Epigenetics is defined as the modification of gene expression without modification to the genetic code. So these types of stressors can change not your DNA, but how your genes are expressed. And so these are some brain areas implicated in post-traumatic stress disorder, or PTSD. And so if we look at the amygdala down here, it's critical in the development of fear response and an emotional response. It's central to the brain's fight or flight response, and we'll talk more about that later. Trauma causes the amygdala to become hyperactive and hypersensitive, leading to exaggerated stress responses. Minor stressors or stimuli trigger intense emotions like fear, anxiety, or aggression. And now if we look at the hippocampus, it's in charge of memory and learning. It's also the place for storing memory, and especially the distinction between past and present experiences. And so when a person has experienced significant trauma, it shrinks, leading to problems with memory and difficulty differentiating between past and present trauma. And this is often experienced as flashbacks and a re-experiencing of the traumatic symptoms. And then this third blue box is the medial prefrontal cortex. And so this is responsible for executive functioning, personality, abstract thinking, planning, and behavior regulation. And so this is everything from managing emotions to focusing on tasks, filtering out distractions. So they'll weighing pros and cons and making a decision, self-regulation, controlling your impulses, delayed gratification, and being able to shut down your impulses or any reactions or actions that might not be congruent with the larger goal. And so in trauma, it becomes underactive, and this interferes with all these things I just listed. So dysregulation, structural changes, and poor communication between these areas can contribute to a disruption in the patient's emotional response, but also their motivational pathways. And these areas are also directly implicated with substance use disorder. So we can see how these patients are more vulnerable to substance use disorder because the same areas of the brain are affected. And so the stress response once was thought of as, I think, fight or flight, and hopefully everyone here has heard of that. But there's a third stress response, and that's the freeze response. And this manifests as shutting down, failing to engage, or dissociation. And dissociation is this sense of feeling completely disconnected from the world. And so a sustained stressor a sustained stress response is a survival mechanism. And so patients with a maladaptive trauma response spend a lot of energy suppressing the past instead of living in the moment. And now we're going to just briefly touch on substance use disorder. And so these are the DSM-5 criteria for diagnosing a SUD or a substance use disorder. And if you, I know they're small on the right, but if you see it says substance taken in larger amounts, you can just insert whatever substance that we're thinking about or we're interviewing the patient for. So alcohol, cocaine, meth, opioids, etc. I like to think of these as the 3 Cs, although the 4 are listed here, and that's correct too. But for me, I just simplify them into 3 Cs. So I think of them as cravings / compulsion to use. And so I will ask my patient if they have cravings for the drug. And then a lot 2 is a loss of control, and 3 is use despite negative consequences. And this isn't really, this is one of our favorite things to talk about, but we're going to keep going because we have a lot of other things to talk about today. So these are some areas of the brain that are implicated when you have a patient who has substance use disorder. They're affected. And so as you can see, these are areas that we just discussed on the slide when we were looking at the areas of the brain affected by PTSD. So we have let's start with this yellow, the nucleus accumbens. This is the endpoint for all drugs of misuse. All drugs of misuse have different pathways in your brain, but their end effects are here. And this is really responsible for our reward / motivation pathway. We have a really brilliant colleague, Dr. Morrow, who gives these amazing talks on the neurobiology of addiction, and he argues that although it's this cycle is often called the reward pathway, that it's actually a motivation pathway. But regardless, we're going to, by affecting this area, you're going to increase the reward drive or the motivation drive. If we look at the blue, the amygdala, this is responsible for emotional regulation and drug craving. And then the green, the hippocampus, where our memory center, this can really be implicated in a lot of drug memories. And then, the red is the prefrontal cortex, which really provides a lot of the inhibitory control. And so when a patient has substance use disorder, these areas are not functioning as they should be, but the connections to them are also weakened. And so, if you have the thought that, you want to not go to work and instead you want to have a drink and drink all day, this weakened connection to the prefrontal cortex could allow you to override that thought and say, no, I have to go to work due to these weakened connections. And so the changes that occur in someone with PTSD may enhance the rewarding effects of some substances, which make it more likely that the individual will continue their substance use. Okay, and so when we think about an individual's vulnerability to substance use disorder, we need to think about all the things listed on this slide. Studies suggest that there's a strongly genetic predisposition for substance use disorders, with some research suggesting that 50 to 60% of vulnerability for alcohol use disorder is genetic. But that's only 50%. The other 50% is your environment. And so, it's who's around you, who's in your family, what kind of adverse childhood experiences you have, which we'll talk about in a minute. And then it's also availability. You can have these genes, you can have a strong genetic predisposition to substance use disorder. But if you grow up in an environment where there are really limited access to alcohol and illicit drugs, you might never be exposed and you might never develop a substance use disorder. And so these two sides really need to work together for a person to end up with an actual use disorder. Now we're going to transition and discuss the study on adverse childhood experiences, which is often shortened as ACEs. And so between 1995 and 1997, the Centers for Disease Control, or the CDC, and Kaiser Permanente, an HMO, collaborated to interview 17,000 people. And this site was based in San Diego. And so they asked these people if they had experienced any any of the childhood experiences listed on this slide. Physical, emotional, sexual abuse, physical or emotional neglect, a parent with mental illness, an incarcerated relative, if a mother had been treated violently, which refers to witnessing a mother or a mother figure, like a stepmother, be physically harmed or be threatened physical violence by a father, stepfather, or boyfriend, a parent with substance use, and divorce. And so the study was really pretty profound. It showed that people who reported 4 or more adverse childhood experiences experienced a 4 to 12 times increased health risk for alcohol use disorder, drug misuse, depression, and suicide attempts, a 2 to 4 times increase in smoking, poorly self-rated health, greater than 50 sexual intercourse partners, and sexual transmitted disease, and a 1.4 to 1.6 time increase in physical inactivity and severe obesity. And it also found that the ACEs experience had effects on physical health, with people who reported a score of 6 or more dying on average 20 years earlier than those without um, a score of 6 or more. And so if we take a step back, that's really that's a massive difference in life expectancy. Um, and everything else controlled. Um, the it was people who had these childhood experiences who had a lower life expectancy. And if we look specifically at ACEs and substance use disorder, if you have 4 or more ACEs, you're 7 times more likely to develop an alcohol use disorder, 5 times more likely to use illicit drugs, and 10 times more likely to inject drugs. And so now that we've seen all that data, I just want to take a step back and say, that there's obviously a lot of life events that are not accounted for by this measure that Melissa did a great job describing earlier. And I just want to stress that every person's experience is individual. And so it is, I think it's somewhat difficult to really it can be difficult to take this data in the study and translate it to the patient in front of you. For example, if you have a patient who had a parent with, well-controlled and well-treated mental illness, that's obviously not a similar experience to a patient who had 2 parents with untreated mental illness. Those aren't experiences that you could really compare, but they would be the same on this scoreboard scores this measure. Melissa and I also even talk about how this is a self-report. And so a patient has to recognize that they experienced some of these categories. And that can be difficult when that is how you grew up and that is your experience and it's been normalized. We also have a sense of wanting that we love our caregivers and we want to protect them. And so I think for many, we try and see them in the best light. And Melissa has this patient that we often talk about when she was in clinic and she was just interviewing people on their number of ACEs. And I asked her to share the story.
Yeah, thanks, Shiva. So yeah, I had a young woman in clinic, and I asked her if there was any history of trauma, and her answer was no. And as we continued through more specific questions around childhood experiences, she shared that her parents actually injected her with drugs. And that's obviously a very traumatic experience. It's abuse. And it would just goes to show that this was what she knew, and she didn't necessarily have an understanding of what trauma is. And so it was a lesson learned that we really need to ask specific questions about what happened to get an accurate report. Okay, so the 4 R's of trauma-informed care are realizing that there is a widespread impact of trauma and understand the potential paths for recovery, recognizing signs and symptoms of trauma in clients and families, staff, and others involved with the system, respond by fully integrating knowledge about trauma into policies, procedures, and practices, and seek to actively resist re-traumatization. So it's important to know that trauma is common, and as we've just discussed, it can affect anyone, whether visible or not. It impacts physical, mental, emotional, and social well-being, and often there's maladaptive coping behaviors that people use, and substance use is one of them. And really a shift from, a perspective shift from what's wrong with this person to what happened to this person, and viewing behaviors as adaptations and not just problems. Expect that trauma can limit emotion regulation, communication, and cognitive capacity. So just because you have a 35-year-old male coming into an appointment does not mean that if you see a history of mental health, or they're coming in for mental health or substance use disorder, they may not present the way that you expect them. So somewhat changing expectations of how someone might present with trauma. So recognizing signs of trauma, and as Dr. Sethi mentioned, there isn't a typical presentation. Some things to look for are hypervigilance, so being on edge, kind of surveying your surroundings, being irritable, difficulty trusting or communicating, recalling details, chaotic presentation, so maybe late to appointments, poor follow through with treatment. So trauma-informed care means recognizing that certain practices, for example, restraints, needles, procedures, the power dynamics, can be triggering to folks with trauma and could potentially re-traumatize. So just adjusting to minimize harm. And then also, as providers that work with people that don't feel good, you witness pain, you witness loss in these folks, and you witness death. And so acknowledging your own experiences and how they may be affecting you as well. So I think the most important thing in responding is facing the person, open body posture, making eye contact, and really is tone of voice. So you could say, "What's going on with you?" Or you could say, "What's going on with you?" And you can feel the difference in tone of voice. And the goal is to make the person feel like they are seen, and that what they have to say is important, and making them feel safe. So treating them like a human being who isn't feeling well and not according to their diagnosis. Response is empathetic, and maybe just checking in with yourself. Am I communicating well? Are my reactions, responses communicating safety and trust? Next slide. So just for some real tangible ways to make someone feel safe, introduce yourself and explain your role. Tell them that you'll be asking certain questions around XYZ, or you'll be talking about certain topics, and the reason for that. This is important as we assess you and important for your treatment. I will tell you what I'm going to do before I do it. Please let me know if you are uncomfortable at any time and I will stop. Please feel free to ask questions, that sort of thing. So resist re-traumatization. I don't think anyone's out to traumatize people. This is often unintentional. Emphasize shared decision-making. So ask about the patient's treatment goals while offering recommendations. Ensure that they know that they're the driver of their treatment. Recognize that a history of abuse can make medical care triggering, especially when patients don't know what will be done, how it will feel, or why it's necessary. Make appropriate referrals. Make sure that they get connected to support services that would help them through their journey of healing. And understand that maladaptive behavior does not absolve patient of personal responsibility. It is still important to set expectations and boundaries. Okay, so this is Principles of a Trauma-Informed Approach, and it just really talks about it's SAMHSA along with the CDC, and it's a training that they did for employees. And really adopting a trauma-informed approach is not through any singular particular technique or checklist. It does require constant attention, caring, awareness, sensitivity, and a possible cultural change at an organizational level. So these are kind of the 6 core points for guiding principles to a trauma-informed approach, and more at an organizational level. So I'll hand it over to you, Sheba, for the case example.
Okay, sounds good. Thank you. So this is a story. This is a case that Melissa adapted from the story of a famous individual. And so she did it, and I adapted it to be the case for today. So a 54-year-old single male with a past medical history of opioid use disorder, alcohol use disorder, and nicotine dependence was in the ICU after a ruptured colon, which required a 6-month hospitalization. So sorry, that the patient was hospitalized for 6 months. Most of it was in an ICU level of care. The patient presents to established care and is rude and proudly non-adherent to medical recommendations. And so in the history, he lives alone. He's self-employed as an actor. His father has a history of alcohol use disorder. His father left the patient and their mother when the client was 9 months old. His parents divorced. His father lived in another country. His mother worked long hours, and the client reports being home alone and feeling parentless and alone. He craved her attention and didn't feel seen by her. He reports periods of intense fear when at 5 years old, he was put on an airplane by himself to fly from one parent to another. He felt intense fear and felt like he had been abandoned. At age 12, his mom remarried, and suddenly he had a stepdad and brothers and sisters. He reported feeling like an outsider in this family. He had his first drink at 14, and at 15, he had a significant fight with his mom and moved to the US to live with his dad. His dad drank daily, and the patient's exposure to alcohol intensified. At age 24, he was cast in a successful TV show. Next slide. And this is just a focus on his substance use history. So he had his first drink, I think I said it was at 14, but he began drinking daily in his 20s. His first opioid use was at age 26. And both his first drink and his first opioid use were very significant events for him. And Melissa will have some quotes that she's going to share in a minute. So his first opioid use was at age 26, and he was soon using up to 1,800 milligrams of oxycodone a day, PO only. No history of injection drug use. He reports 15 substance use disorder rehab treatments, inpatient psychiatric hospitalization. Therapy twice a week, thousands of AA meetings. He has been on methadone and buprenorphine maintenance treatment, but he has relapsed multiple times, with the longest period of sobriety as 2 years. And he currently smokes 3 packs per day, although his surgeon has asked him to stop smoking because he needs to have a pull-through procedure to reverse an ostomy, which he's upset about. He wants to keep smoking.
So this is something we wanted to point out is, the traumatic events and ACEs aren't always the same. ACEs we determined by what the book states, and we can't interview him, so we had to, identify them according to the book. ACEs measure categories, not counts of events. Each ACE category, such as physical abuse, emotional neglect, household dysfunction, is counted once. Even if a person experienced multiple events within that category, the cumulative trauma can be much greater than the ACE score alone suggests. So you can see his traumatic events here and his ACEs. So really, we only have 2 ACEs listed here, but there are several events that took place, and they took place in early, middle, and late childhood. So this is complex trauma. This is happened in the family context. This is ongoing, real difficulty with a sense of self, and really intense difficulty with interpersonal relationships, even into adulthood. And so you can really just see the complex trauma play out in this relationship with himself and others. And you can just see how traumatic events can meet numerous ACEs, and or many traumatic events can meet one ACE. And it really is about the age that this happened, and the time that this went on. And as this person went into adulthood, just continued to experience traumas. This is just really important, the trauma messaging. This is how this person sees himself, others, and the world. This is the lens through which he lives his life. Thank you. So again, these are trauma messages, the way he sees himself, others, in the world. So I am too needy. I'm broken. I can't trust closeness. I'm unlovable unless I perform and make people laugh. People I love will leave me. I am not enough. If I'd been enough, they wouldn't have left me unaccompanied, right? And he's referring to in that being put on a plane at 5, as Dr. Sethi mentioned. He would fly from the United States, from Canada to the United States. And he says not having a parent on these flights, which there's multiple, is one of the things that led to a lifelong feeling of abandonment. And this is specifically how he talks about substance use in relation to his mental and emotional suffering. So the first time he got intoxicated from alcohol was age 14. And he says, nothing bothered me and everything was right with the world. I was at complete peace. This is the answer. This is what I have been missing. This must be how normal people feel. I don't have any problems. It's all gone. I don't need attention. I'm taken care of. I'm fine. So if you think about the opposite of everything that he shares, and that what that experience must be, it's profoundly different. And as Dr. Sethi said, when you have a history of trauma, or have experienced ACEs, it does sometimes make the substance just more powerful. And this was obviously the case for him. He continues to say about alcohol, it allowed me to be content with who was in front of me. It allowed me to control my feelings, and in doing so, control my world. Learning to move forward in life without it was tantamount to asking someone to go about his or her day without breathing. Powerful statement. And I think also goes to show that people that struggle with mental health issues, that struggle with substance use, there is, whether they can put it into words or not, an understanding, like, I am not coping like everybody else. I am not able to manage my emotions like everybody else. And it's terrifying. And so a lot of people will use substances or other maladaptive patterns of behavior to try and manage that. First opioid use was age 26. I swear to God, I think if I'd never taken that pill, none of the next 3 decades would have gone the way they did. As the pill kicked in, something clicked in me. And it's been that click I've been chasing the rest of my life. Nothing could ever go wrong. I remember thinking, if this doesn't kill me, I'm doing this again. And he goes on to talk about how quickly his use increased.
So in the interest of time, I'm gonna skip this slide, but I just want to pause here and acknowledge that this work is difficult. And you know, there's many people that work in our offices, in our hospitals, that may have not signed up to be an addiction provider and a mental health provider with a specialization in addiction and trauma. And so they didn't sign up for this, and so we're not trying to gloss over how difficult it can be. It's hard. But we're hoping that this zoomed out view that we gave you of this one individual can help you with some of the principles that Melissa already mentioned in her earlier slides, where she outlined the response, or how you can approach someone with a trauma-informed lens. I think the first, if you could stay calm and not take it personally, that is, like, I really feel like step one. And then, it takes time to make someone feel safe. And so I think if you could just try and be curious and not judgmental, to quote Ted Lasso, over time, the patient will see that. And this patient was Matthew Perry. And Melissa recommended his book to me, and it's really fascinating. So I recommend it to all of you, and I recommend the audio version because he reads it himself and he's very funny. So in a summary, treat substance use and trauma simultaneously, because otherwise it's a loop. And I would actually go on a further limb and say that you should treat all of the patient's comorbidities as you treat their trauma and their substance use disorder, because really you need to work on all domains for them to really get better. The patient-provider relationship and rapport is critical. Screen and assess for trauma. Grounding skills are very important. And these are a list of some evidence-based treatments for trauma, which we won't have time to go into. And I just want to end with these two pictures. The one on the left is a picture from the Tuskegee study. From 1932 to 1972, the U.S. Public Health Service injected syphilis into Black men to study the effects of untreated syphilis. The picture on the right is Holmesburg Prison. It's in Philadelphia. And from the 1950s to the 1970s, they did a lot of experimentation and development of dermatologic products, also primarily in Black men. So I just want to say, as healthcare workers, when our patients are also suspicious of us, they have a historical reason to be, and so just to try and validate them and listen to them, I think is important.
So the TIP 57 stands for Treatment Improvement Protocol. It's by SAMHSA. It is all about trauma-informed care for behavioral health organizations. It can be downloaded. It's an excellent resource. Trauma-Informed Care Implementation Resource Center by the Center for Healthcare Strategies is another excellent resource for healthcare providers. Ward 5B, this is amazing. I think a really relatable example of how trauma-informed care was implemented. So Ward 5B was founded by a group of nurses at San Francisco General in 1983 who cared deeply about people suffering with AIDS. The unit was founded by nurses and caregivers who recognized the neglect and stigma and fear surrounding AIDS in those early years. And instead of treating these patients like people to avoid, the staff created a more compassionate and humane care environment. So it's a documentary, and there's also a toolkit involved. The Gain Center offers training that helps educate criminal justice professionals about the impact of trauma and how to develop trauma-informed responses. And then Sheba recommended this book to me, What My Bones Know, by Stephanie Fu, and it is a personal memoir by her chronicling her journey to understand and heal from complex post-traumatic stress disorder resulting from childhood abuse. And this is one of the rare resources that shares a real person's story, showing how complex trauma impacts the body, mind, and behavior. And she also shares recordings of her sessions with her therapist. And it's tremendously helpful in how she explains and how you can hear the healing that takes place in this dynamic with this therapist. Okay, and these are our references, and we are happy to answer any questions.
So
Looks good.
you can access this by using the QR codes or the links that are here. We will also email this out after the presentation today, so everyone will get this information if you are unable to get it off the screen. And any questions that we might have. So
We have a question. Can we get copies of the slides for this presentation?
we don't usually send the slides out. The webinar is recorded and will be on our website within a few weeks, and that's usually how we share the information out.
How up to date are the statistics on ACEs? Do you know if there are other studies being done? The ACEs original study is an older study, but there are ongoing studies that are more recent. You can just Google it or look in PubMed for ACEs. And it says here the survey is expired. Katrina.
Sorry, I was muted. I will check into that. Give me 1 second.
And those are most of the questions.
I have a couple more. Can you hear me?
Yep.
Okay. Home visitors provide weekly in-home or community visits to support parents. When parents request assistance with obtaining mental health services to heal from traumatic experiences, what treatment modalities, approaches have been effective that parents can explore to determine if it meets their needs? So I can take this one.
Let's see.
So I assume this is often through community mental health, and community mental health workers are generally educated in trauma-informed care. Really, the treatment modalities it's excellent to work within a family, and the age of the person that is experiencing the trauma is really important here, right? Because the modalities are going to be according to the developmental age that are chosen. So, and it also is, I think, really important that parents understand how to help the young person help self-soothe. I worked with a case one time where it was obvious trauma, and I would, in my session with just meeting with the child, I would look at the child and I would say, what was your favorite part of the day today? And they would give me that. And then I would say, tell me more about that. And I would ask questions about that. And that was so profoundly, and this is one case, I'm not saying I'm this great therapist or anything like that, but it was so profoundly helpful to this young person to feel seen. And the parents would come back and go, what are you doing? And I said, you know what? I would recommend that you turn off all devices, like any, get rid of any distraction, and whether you choose a time of day before bed, you know, at dinner, after dinner, you know, ask about her day and talk about and really inquire, make her feel seen and heard and listened to. So it's hard for me to give like specific modalities or, you know, approaches. Really depends on the age and stage of development. With intergenerational trauma, if the child experiences the same environment, the same trauma is repeated. How has CPTSD with the substance use now has CPTSD with the substance use disorder, etc. If they could become aware of it after creating a safe enough environment and the dissociative amnesia lifts the trauma, they begin to heal through recovery and mental health support. Can they increase the life expectancy? And do you have any info on patients beyond this? That's a good question. I don't.
That's a good question. I don't know if that particular question has been studied, but again, I feel like this goes back to the idea that it's just so individualized. And so if we think about any condition, treated versus untreated, the person who's treated and you know, like if we think about diabetes, you know, I would guess that in most instances, if we have someone with the same hemoglobin A1C, the person who's treated would have better outcomes than the person who's untreated. But I think it's difficult. I'm having trouble generalizing that.
Yeah, I think that was a good answer. I think, you know, as it with any condition, as it's treated, hopefully, hopefully you're living more healthy and able to have a longer life and quality of life. With the resources provided here, do you think someone with complex trauma would need a heads up before reading the book by Stephanie Fu, speaking along the line of re-traumatization to the reader? She actually gives a really good disclaimer and says that the beginning of the book is a history of her childhood trauma. And so she does give a warning and does encourage people to listen to it if they can. But that's a very good point.
Okay, so I just want to update the link for the CEUs is fixed. It is working. And we are at time. So I want to thank you, Melissa and Sheba, for presenting today. And again, everyone will get the information for the credits sent to them by email. And thank you for joining us and have a great rest of your day.